Hi friends, I am Dr. Amarjeet Singh Bhadwalia, practicing at Sarhan, Punjab. I was always fascinated about MSICS or manual SICS, and I am very much passionate about it. I guess every case is a challenging case, maybe a case of cataract or as simple as pterygium excision, so complications are bound to occur. But the only thing is how to manage these complications. So friends, I am going to operate a case with manual SICS 2.8mm incision. I highly recommend not to use this technique in cases of grade 3 and grade 4 cataracts, as this can lead to devastating complications. I always teach my students to make their steps as simple as possible. And friends, the only thing what I teach them is, if you respect the tissues are going to respect you the next morning. So friends, let's go and operate.
Hello friends, let's start the case. This is female, 50 years old, left eye, having trap done outside at 1 o'clock position. Cataract is grade 2, so I'll be doing this case with 2.8mm incision clear cornea. I've seen the literature till date. There was no case which was done with manual SICS with 2.8mm clear corneal incision. So using 2.8 keratome, we are going to go inside the eye. You have to be very, very gentle. Roughly 1.5mm incision goes inside the cornea, clear cornea. The posterior lip has to be absolutely clear cut so that you don't get any surprises of astigmatism post-op. In a similar fashion, you do side port. So far, so good. So under air bubble, inject trypan blue for 4 to 5 seconds. Then wash it with BSS, and you can go for capsulorhexis. The difference between phaco and manual SICS rhexis is that in M6 the rhexis has to be slightly bigger because you have to take out the nucleus out from the bag. So we try to make it around 6mm incision. Going on absolutely fine. Don't make haste. Oh, look here. What's going to happen? There is runaway of the rhexis. Never to pull this rhexis edge. Never try to bring it to the center, because this is going to damage the zonules and vitreous is going to come out. Now, why this thing has appeared is because of the shallow AC. Nothing much to worry about. This is the beauty of SICS. Fill the anterior chamber with visco and cut the edge with micro 1 or Caesar. Complete your rhexis. Now the only thing I have to take care is not to put much of pressure on the zonules where there is capsular runaway. Rest of the procedure remains the same. Do the hydrodissection. Bring one of the edges of the nucleus out. Put visco above and below. Then using a Sinskey hook, gently dial the nucleus into the anterior chamber. So I think 30% of your work is done. But here the challenge is taking out such a large nucleus through 2.8 millimeter incision. This means the nucleus has to be divided into smaller pieces, maybe 4 to 5 pieces. So here I'll be using wire vectors, which is customized, custom made, and a Sinski hook. So we divide the nucleus into 3 pieces. Go very gently, very slowly. This is one piece. While going back, this is another piece, and then you take out. Once again, put visco above and below the nucleus. Using wire vectors alone, stabilize the globe using micro forceps, single tooth forceps. Put your wire vectors, gently press the posterior lip and bring the nuclear pieces out one by one. This can be repeated 3 or 4 times. Now here you can see a smaller piece which is there. This can be fragmented using visco. Just go to the edge, put a little bit of visco, and the smaller piece gets separated, which can be later taken out using a wire vectors like this. This surgery may be a bit difficult. You must be thinking it's a heroic surgery, but the only thing is I just want to show you that yes, manual SICS can be done through 2.8 millimeter incision. I have seen the literature of about 10 years. Till date, nobody has done it clear corneal 2.8 millimeter incision with SICS technique. Probably this is the first time in the world, I suppose. Anyhow, so far so good. You have to repeat taking out with wire vectors 4 to 5 times. Needs copious amount of visco so that there is no endothelial damage. Now these 2 pieces are very small, so this can be taken out very easily, either with wire vectors, or you can just take it out with hydroid or visco expression. Cornea seems to be slightly okay. %90 of your work is done. This we call it as visco expression. Put the visco and gently press the posterior lip. The whole thing is going to come out. Now I think you can appreciate the PI of trab which was done at 1 o'clock position. Posterior segment was absolutely normal in this case. CD ratio was about 0.2 to 0.3. Pressure was normal. So after injecting the IOL, the other haptic can be easily dialed inside the bag. Once the IOL is positioned, I put little bit of carpine to make the pupil slightly irregular, and I think my case is done. We'll be showing you the first post-op case to what I have done. We'll also show you the site of incision, and let's hope patient gets a good vision. Pre-operatively, patient had, with the rule, 0.5 diopters. Look at this, cornea seems to be absolutely clear. Air bubble is very much visible. And now look at the site of incision. It's so small, clear, absolutely good. Now let's see the vision.
Again. Put up. Again. Again. Again.
C T P A N O.
Very good. First class.